Your patient is bleeding out, massive hemorrhage, time for that massive transfusion protocol. So it's the perfect time to sit down and review some evidence. And not just a quick review, we're going to do a lengthy, deep dive review into the evidence so that hopefully we can all better understand and manage massive hemorrhage. And there are a ton of questions here. What's the best ratio of blood products? What's the role of fibrinogen or TEG or Rotem? Calcium, temperature management? Should we be using whole blood? If you have questions about any of those topics, we're going to cover them here. Now, if you do actually have a patient bleeding out in front of you, you might want to bookmark this video for later. The first ever video on First 10 EM, I'll see if I can link it here somewhere, was a simplified approach to the clinical management of massive hemorrhage. In this video, we're going to go a lot deeper so that you can truly be a master of massive hemorrhage, so that you can design better massive hemorrhage protocols for your hospital. Welcome back to First 10 EM. Last year, I was invited to Perth, Australia to give a series of talks, and one of the talks that was suggested was a talk to the anesthesiologists about massive hemorrhage. But here's the thing. Anesthesiologists are smarter than me. They see massive hemorrhage way more often than me, and so I had a bit of a challenge on my hands if I didn't want to look like a complete idiot. And really, that just left me with one option. I had to lean in to one of the most embarrassing personality traits that I have. I had to lean in to my nerdy side. Now, for people who are new to First 10 EM, who don't know me, I'm a community emergency doctor from Toronto, Canada. But what I'm really known for is being a massive nerd, maybe one of the biggest nerds in medicine. The most used link on my computer is PubMed. I read the medical journals every morning with my coffee. It's not uncommon for me to spend a year or more researching a topic, no matter how boring that topic might be. I have a 25,000 word, 7-part article on laceration repair on my blog that I probably spent, 3 years reading articles for. So I told you, my nerdiness is embarrassing. And so that's what I did for this talk. I spent more than 6 months painfully reading every single piece of evidence that I could find on massive hemorrhage. And that's how this talk was created. So that's enough of my rambling intro. Let's just jump right in. Here's a recorded version of the talk on the science of massive hemorrhage. On its face, massive hemorrhage is a pretty simple topic. The patient is bleeding out. We really only have 2 jobs. Try to stop that bleeding and put some blood back into them. It couldn't be simpler. You could probably teach this to an orthopedic surgeon, but of course it's not that simple. We all had to memorize the clotting cascade at some point, add in the role of temperature and endothelial damage and calcium, and this topic quickly becomes a mess. And this is one of those areas in medicine where you will hear some very strong opinions. But I'll tell you, I'm always wary of strong opinions. I think there might be a general rule in medicine: the stronger the opinion, the weaker the evidence. And I understand where the strong opinions come from. Look, we've made a lot of mistakes in the past of transfusion medicine. It's really easy to forget about calcium or platelets or fibrinogen in the middle of a trauma resuscitation. And so when we're teaching our students, we tend to use really strong and really simple language, trying to emphasize these learning points so that they aren't forgotten. But the problem with strong language, even when it's in teaching, is that it can easily slip into dogma. And when we don't understand why we're doing what we're doing, when we don't understand the uncertainty in our practice, that can lead to bad decisions. And so the goal today is to walk us back a little bit from the dogma and make sure that we understand the evidence behind our actions. And I think that will allow us to be a little bit more cutting edge, because we all know when to follow the dogmatic advice. But we'll also know when it's appropriate to break from clinical guidelines and do something different than the standard massive transfusion protocol. Now, unfortunately, I think I can probably summarize all of the evidence for this topic, everything we're going to discuss, on a single slide. It's not good. Dare I say it's mostly crap. So unfortunately, despite spending many, many months on this, the ultimate conclusion I'm going to leave you with is very simple. There is massive uncertainty. Despite some very strong opinions, we really don't know what we're doing. And although that can sometimes be distressing, it is important to know because it allows us to anticipate the quote-unquote medical reversals that are definitely going to come when new evidence comes along, and it allows us to think outside of the box a little bit. When the evidence is rock solid, your hands are somewhat tied. You have to follow the cookbook. But when there's this much uncertainty, there's a lot more room for clinical judgment. Now, before we go too deep into the evidence, I want to go quickly through what is often thought of as the best current practice for massive hemorrhage in the emergency department. A quick recap of our current practice so we can understand what questions we're trying to answer with this evidence review. So, massive hemorrhage protocol in the emergency department. Step 1, immediately control any source of bleeding that you can control. So that's direct pressure or tourniquets for any external bleeding, pelvic binder, whatever we can do. Immediate priority is keeping the patient's blood inside their own body. Step 2, initial resuscitation with uncrossed blood while determining whether a massive hemorrhage protocol is actually needed. Not everybody needs the whole shebang of a code transfusion. Most people stabilize after a few units, and this whole massive transfusion protocol eats into a lot of resources. And that's one of the topics we'll come back to. How do you know when to activate the protocol? Guidelines suggest different tools or scores. My personal cutoff is 3. If I hit 3 units and the patient is still sick, I'm moving into massive hemorrhage. Step 3, activated the massive hemorrhage protocol and focus on balanced transfusion. The usual recommendation you'll run into is 1:1:1 packed cells, platelets, and FFP. And we'll come back to that because 1:1:1 is almost certainly wrong. Next step, or we might call it 3A, consider the blood components that aren't part of that 1:1:1 transfusion. Mostly we're talking about calcium and fibrinogen. 1 dose of calcium for every round of transfusion, and replace the fibrinogen if we get to a level less than 1.5. These 3 steps are sometimes referred to as the ABCs of massive transfusion. A is for activate, call for help, activate the protocol. B is for balance. C is for calcium and cryoprecipitate. Step 4 is all about trying to prevent further bleeding, so TXA, reverse anticoagulation. Step 5 is about really good supportive care, avoid hypothermia and acidosis like the plague. And then step 6, have a good endpoint for the massive transfusion protocol. Remember that these protocols are intensive, incredibly resource intensive behind the scenes, so you want to have some kind of reminder to let the blood bank and the lab know that they can stand down and start looking after other patients again. So that's the 6-step approach for the ED, made very, very simple, right? Stop the bleeding, start with uncrossed blood, activate the protocol using balanced transfusion, not forgetting about calcium and fibrinogen, TXA and anticoagulation reversal, supportive care, and have an endpoint in mind. And despite being simple, all these steps require coordination between multiple areas of the hospital. It's very easy to forget a step in this algorithm if you haven't planned for it and if you haven't practiced it. So my major clinical lesson after running a number of these is that you need to practice. You need to do simulation, and not just within your department, but also with the rest of the hospital, the lab, the porters, if you want this to run smoothly. And this basic approach also gives us a nice guide for the questions we should ask about the evidence. What is the best trigger for a massive transfusion protocol? What's the best ratio of red cells, platelets, and FFP? What's the role of fibrinogen and other blood products like PCCs? What's the role of testing, in particular things like viscoelastic testing? And what's the evidence for calcium, for temperature? Those are the questions I'm going to try to answer in this relatively lengthy review of the evidence. Now, as I said, I spent months reading literature for this one. There's no way I'm going to be able to cover every single paper into this presentation. I have a website called First 10 EM, and I have a long blog post with all of the information, all of the references, a bunch of links. So if I say anything surprising or anything interesting that you want to follow up on, just check out the link on first10em.com. All right. Let's jump into the evidence behind some of these decisions. We have a bit of a tightrope to walk when we're thinking about activating massive hemorrhage protocols. On the one hand, if we wait too long, a patient who really needs blood could suffer needlessly. On the other hand, these protocols usually shut down basically the entire hospital, right? All of the hospital's resources get focused on this single patient at the expense of every other patient. There's tremendous potential for harm. Therefore, the decision about when to activate is really important, and it makes sense that we would want some objective tools to try to help us. And a number of tools have been developed: the ABC score, the TASH score, the RABT score. I'm not going to go into any in detail because none of them are usable. The evidence is garbage, and the performance is garbage. The evidence we have is entirely retrospective studies, and even in very low quality studies at high risk of bias, the sensitivities and specificities are bad, like definitely below 90% and probably well below that. None of these rules have ever been compared to, basic clinical judgment. And it seems very likely that clinical judgment is going to be at least as good as these rules because the components of these rules are super straightforward. Vital signs, mechanism of injury, a fast exam of its trauma. That's it. These rules are going to have a very hard time beating clinical judgment because they use the exact same factors that we use in clinical judgment. So just forget about decision rules. This is going to be a judgment call. I like basing my judgment around what's called the critical administration threshold. I start with 3 units of packed cells, and then I have a hard stop decision point. I know in my brain 3 units is the decision point. A ton of patients, even patients who look awful, sick to start with, get better after 2 or 3 units, and obviously we are not activating. But if my patient still looks bad, like they look like they need more blood after 3 units, that's enough for me. That's my threshold. I activate our code omega, or massive hemorrhage protocol. There isn't good evidence for this, but it's good to have a hard cutoff in your brain so you don't have to make this up every single time. The uncertainty around trigger thresholds for massive transfusion is a pretty good argument for what my friend Scott Weingart calls the stat pack. It is exceedingly costly and time-intensive for a hospital to run a massive hemorrhage protocol, but in many hospitals that I work at, that is the only way to get blood to the bedside stat. There always seems to be delays unless you activate the whole shebang. Instead, every hospital should have a stat pack, 3 or 4 units of O-negative blood that can be brought to any bedside in the hospital immediately, but without activating all the other components of a code transfusion, which are more time-intensive and costly. Now, the units should come in a cooler so they can be returned if they're not used, and if the patient improves on those units, you avoid the massive transfusion protocol. But if they don't, then it's an automatic trigger. You don't even have to think about it. If the patient still needs more blood, if somebody calls for more blood after a stat pack, they are automatically in massive hemorrhage. This approach is obviously good for clinicians. It gets us blood when we need it. But blood banks should also go for this because it really should decrease the number of times that we call for the more intensive massive hemorrhage protocol, and that really should help them out. All right, let's jump right into the meat of the topic. Once you've activated, what should you actually be giving as part of the massive hemorrhage protocol? And the in vogue answer these days is that we want balanced transfusion, a 1-to-1-to-1 red cells, plasma, and platelets ratio. And physiologically, that makes some sense, right? Patients are losing a lot more than just red cells, so why don't we give them back more than just red cells? But like a lot of things in medicine, the fervor for this new treatment is probably unrelated to the level of evidence for that treatment. Balanced transfusion came into vogue based on military data out of Iraq and Afghanistan. I'm not going to go that deep into that data in this talk, aside from the quick mention that you really can't trust the headline news. The thing to be aware about is survivorship bias. It takes time to thaw plasma. The patients that survive longer get more plasma. That doesn't mean that the plasma is saving lives. In fact, it's the exact opposite. They're just surviving long enough to be given plasma, perhaps in spite of the plasma. Being given plasma is actually a marker of being less injured because you survived long enough to have it given. There are really just 2 RCTs of balanced transfusion. Both are in the setting of trauma. Let's start with the one that everybody knows about, PROPER, with 680 trauma patients with massive hemorrhage randomized to either 1:1:1 or 1:1:2. And despite being used as a rationale for a push for 1:1:1, it was actually a negative trial. A lot of people seem to forget about that. Their primary outcome was mortality, and there was no difference between the 2 groups. Now, this trial is far from definitive. It might have just been too small. The point estimates do actually look a little bit better in the 1:1:1 group. But it's pretty important to recognize that our single largest trial on the topic is negative. That seems to be lost in a lot of the conversations on this topic. 1:1:1 is definitely not standard of care. And of course, the biggest problem with this trial, they did not use the correct control group. At the time of this trial, most patients weren't getting any empiric platelets or plasma at all. Standard of care at the time of the trial was transfusion with just red cells alone. And then we played catch up with FFP and platelets based on the labs later. And without that standard care control group, we have no idea if 1:1:2 is even better than 0:0:1. Is balanced transfusion needed at all? Now, there is one other trial of balanced transfusion that looks at that specific question. Now, it's just a small pilot RCT, 78 adult trauma patients from my hometown of Toronto, and nobody ever talks about this study. But I think it's important to know that the results are exactly contradictory to PROPER. Mortality in the 1:1:1 group was 33%. In the control group, which was lab-guided plasma and platelets, mortality was only 14%. Now, this is just a tiny pilot study, but an 18% increase in mortality is bad, right? It really does not look like 1:1:1 is a good idea. And inconsistent data like this really should decrease your certainty a lot that balanced transfusion is a good idea. Now, one of my big concerns about this topic is indication creep. Over the last decade, as 1:1:1 has become popular, I think our threshold to give FFP and platelets has dropped a lot across the board. We start these protocols in much healthier groups of patients. And I think we see that in every day in practice. There's an observational study looking at 1,700 trauma patients who received less than 10 total units of blood. So they didn't end up meeting that threshold for massive transfusion. And the more platelets and the more FFP they were given, the more adverse events that there were. There's clear evidence of harm if we start using this treatment protocol in the wrong patients. Now, it's really hard to know how to translate this data into clinical practice. Don't let anybody be dogmatic with you. There is a ton of uncertainty here. We clearly need more research. But what do you do tomorrow? Well, before we try to answer that question, I think it's worth looking at other data that is related and might help, guide our judgment about whether this whole 1:1:1 approach makes any sense. So we can look at data for, individually for plasma and platelets by themselves, and we can also look at some data for whole blood. And that might tell us whether we think 1:1:1 is a good idea. So when we're talking about balanced transfusions, really we're talking about adding FFP and platelets to our normal red blood cell transfusions. So let's start with FFP. For FFP, there are 2 pre-hospital trauma trials that need to be considered. It's a little bit confusing. The PAMPER trial might be the best overall evidence for a balanced transfusion strategy, better than PROPER for sure, even though this doesn't actually look at balanced transfusion at all. It's a multicenter RCT. Severe trauma patients were randomized to either crystalloid or plasma. The primary outcome was death, and it was a lot lower in the plasma group, 23% versus 33%. So a 10% absolute reduction in mortality is incredible. In some ways, maybe it's too good to be true, and this was an unblinded trial. It's hard to know, but honestly, this is the best individual argument, a very strong argument for benefit from FFP in that whole 1-to-1-to-1 strategy. Unfortunately, the refill study, which was supposed to be the big confirmatory follow-up study in some ways, it's slightly different than the Pamper trial. This time, saline was compared to both PAC cells and FFP, which seems like it would actually be better for trauma than just FFP alone. I mean, trauma patients need blood cells as well. And this time, the results were definitively negative, right? No differences at all between the two groups. I find it really hard to make sense of these two trials, aside from the fact that unblinded trials often show us things that don't come true in follow-up research. But Pamper and refill seem to say two very different things. Now, those are the most important individual studies, but there are a massive number of publications looking at FFP. When I started this research, I thought I would be able to get a pretty definitive answer on the value of FFP. Some pretty clear answers about harms and benefits, so I could clarify this in my mind. But I gotta tell you, I was very disappointed. The quality of these studies is so low that it's hard to draw any solid conclusions. There's a systematic review from 2012 that looked at any RCT that used plasma for any condition. So we're talking trauma, cardiac surgery, warfarin reversal. They looked at its use both prophylactic and therapeutically. They found 80 RCTs. So that's a pretty good start. But these are tiny trials. These trials have groups of 20 patients each. Less than 20% of these trials were clearly blinded. So low quality, small trials. But their overall conclusion, they could not find any consistent benefit from FFP, either therapeutically or prophylactically, in any of the conditions that they looked at. With 80 RCTs, that's a little concerning to me. So I'm going to come back to this slide over and over and over again. There is massive uncertainty in this data. Our two biggest trials go in opposite directions. There are physiologic reasons for sure to think that FFP would be helpful, but the fact that you can have 80 RCTs without demonstrating a convincing benefit makes it pretty unlikely that empiric 1-to-1 FFP and balanced transfusion is going to be a magic miracle cure with dramatic effects, right? If FFP was that important, we would probably see some benefit with 80 RCTs done. On the other hand, I think the one thing that we can be certain about is harm. There's reasonable evidence of harm. Trolley or acute lung injury is only caused by the plasma component of blood. You can't get it from packed red cells. And although it's a relatively rare complication, it's a complication specific to plasma, to FFP. And plasma has all sorts of immune modulators that increase the risk of inflammatory reactions. I already mentioned that trauma observational data that suggests that among patients who don't get the full massive hemorrhage protocol, the use of FFP increases adverse events. And that's mostly ARDS, which makes sense because of all the immune mediators. And that happens in a dose-dependent fashion. So there are lots of reasons for us to be very cautious about our use of FFP. Overall, the data for FFP is pretty weak. There's no good evidence of benefit. There are clear harms. It's impossible to make definitive conclusions, but my guess, after sorting through all of this data, is that we're currently overusing FFP, maybe overusing it by a lot in current clinical practice. And that my guess is that if we can get some better evidence, future massive hemorrhage protocols will trend towards less FFP, not more. I wouldn't be surprised at all if in the future we see ratios of 1-to-1-to-3 or 1-to-1-to-4, or maybe we might even revert all the way back to waiting on labs and treating only if coagulopathy develops, rather than just giving FFP upfront empirically. Now, while on the topic of FFP, it's worth talking briefly about Prothombin complex concentrates. FFP is a pain in the ass to use. It takes time to thaw. The number one complication of FFP in general practice, not in trauma, but in general practice, is circulatory overload because of the large volumes needed. There are allergies. There's a risk of bacterial contamination. There's all the inflammatory stuff and trolley that I talked about. For all of those reasons, PCCs are, at least on paper, theoretically, a much better option. But for the most part, in the context of hemorrhage, the evidence just isn't there yet. A 2020 systematic review found 17 papers, but they were all observational. 15 of the 17 were retrospective. So we're talking incredibly low quality data. Most of the data comes from cardiac surgery, where there doesn't seem to be any benefit at all. If you look at the trauma patients, there was a statistically significant association with improved mortality. However, we have to be really cautious with retrospective observational data, because when you look at the trials themselves, the patients given PCC look nothing like the patients who were not. So confounding is going to be a huge issue. And until this year, there was just one tiny pilot RCT looking at PCC, and that was in bleeding cardiac surgery patients. It wasn't a great trial. It wasn't blinded, but there was no statistical benefit. Although, I'll give you, if you look at the point estimates, the outcomes did look better in the PCC group as compared to FFP. But that changed last year. The one big RCT published is a double-blind, multi-center trial looking at adult trauma patients needing massive transfusion. They were randomized either upfront to either get 4-factor PCC or placebo. And there was no benefit in their primary outcome of total products used. There was no benefit in mortality. There was an increase in overall thromboembolic events. So in our best data so far, PCCs, which should be a better version of FFP, show harm. Not very promising. So look, the data is clearly not strong enough for routine PCCs right now. I think it's important to keep this option in the back of your mind, depending on where you work, especially if you work in smaller centers or do transport work. There's a lot of places that don't have FFP available at all, and in those scenarios, at least on paper, PCCs are essentially giving you everything that FFP does. So aside from cost considerations, there are definitely times when PCCs seem reasonable. But that assumes that empiric FFP is a good idea. That assumes that this whole one-to-one-to-one thing is a good idea. In fact, theoretically, PCC should be much better than FFP. So the fact that there's no benefit at all and actually harm in the ProCoag study is interesting. To me, that sounds like a hint that we've been overzealous in our adoption of early empiric FFP as part of these balanced transfusion regimens. All right, the other component of balanced transfusion is platelets. This data, unfortunately, at least in my eyes, is even harder to summarize than the FFP data. Really, there are no trials looking at platelets on their own in massive hemorrhage settings. So probably the only answer I should give you is we don't know. There's a pretty good association between lower platelet levels in trauma and bad outcomes, but there are a lot of confounders there. An association does not mean that giving platelets empirically is a good idea. There is also some pretty good data out there that says platelets take a pretty long time to fall in trauma as compared to the other blood components, at least, a couple hours. So there may not be a rush to give them. You might be able to, and you might want to, just wait on lab values rather than giving them empirically. Now, if you're trying to extrapolate the data from other settings with platelets, it's very mixed. There was the famous patch trial a few years ago that looked at platelets in spontaneous intracerebral hemorrhage in patients who were either on aspirin or Plavix, and it had to be stopped early because of significant harm in the platelet group. So, of course, we got to keep in mind platelets can cause harm. But there are a number of RCTs looking at platelet replacement in thrombocytopenia from malignancy. And overall, it does seem to decrease the amount of critical bleeding that these patients see. Last year, we also had the PACER trial that was published that showed that prophylactic platelets for patients who have platelet levels between 10 and 50,000 before placing a central line also resulted in less bleeding. So, I don't know, the evidence here is mixed. I think there are some very clear harms from platelets, but there also are probably some benefits from platelets in the right patient population. The evidence-based medicine conclusion is we just don't bloody know. I don't think this data really helps us determine if 1:1:1 is a good or a bad idea. But I think, there is some indication, at least in the observational data, that we have time. That platelets don't fall that quickly, and so that just waiting and seeing what the platelet level is might make sense, rather than giving everything empirically. Now, theoretically, the patient is losing all components of their blood, so it makes sense to give it all back to them. So on paper, whole blood seems like a very good idea. Basically, it's 1:1:1 on steroids. It has everything that you need perfectly balanced. The combination of 1:1:1, 1 unit of red cells, 1 unit of platelets, 1 unit of FFP, results in an approximate 600 ml bolus that has a hematocrit of 29%, 88,000 platelets, and 65% coagulation activity. In contrast, a 500 ml bolus of whole blood has a hematocrit of 33 to 43%, 130 to 350,000 platelets, and 86% clotting activity. On paper, whole blood clearly looks a lot better. Unfortunately, at this point, 2024, the data just doesn't match the theory. Like balanced transfusion, there is a bunch of observational data, and it's often spun as positive, but the patients being given whole blood in these studies are just completely different from those being given standard transfusions. And the benefits here are only actually seen after statistical adjustments. So even with the spin, there isn't a clear benefit. There's a systematic review from this year, or last year now, I guess, that talks about an improvement in 24-hour survival. But there are just so many confounders there. And I think even more importantly, in their own data, there's no survival benefit by 30 days. So maybe there's short-term benefits, but it all seems to be washed out by longer-term adverse events. There is a single RCT. It's a small pilot RCT of 107 trauma patients, and there were no differences at all. Mortality at 24 hours was 11% versus 10%, so identical. There was no statistical difference, but it makes me nervous that by 30 days, mortality was 22% with whole blood as compared to only 14% with component therapy. Right? That's not statistical, but is not going in the right direction. There's another quasi-randomized trial that you might hear about. They assigned whole blood versus component therapy based on days of the week, odd versus even. That quasi-randomization clearly did not work because 70% of the patients got component therapy, and this is really low-quality data. In the end, they had 253 trauma patients, and there was no statistical difference. You could talk all day about this trial. The point estimate does favor whole blood, but the trial was just way too biased to draw strong conclusions. So clearly, I would say at this point, whole blood is research level, not clinical level. I know a lot of people have jumped the gun on this, but there's just not evidence supporting the use of whole blood right now. I think this evidence, when we finally get it, will tell us a lot about balanced transfusion. I would expect, theoretically, that whole blood should be much better than 1:1:1. But so far, I actually think the data that we have, the one RCT that we have, is pretty negative, which makes me even more skeptical about the whole concept of 1:1:1, although really this is probably just too weak to say anything. But there are a bunch of ongoing trials, so this will be an interesting area to watch in the coming years. So let's jump back to the main question, right? Let's try to balance the entire idea, or to summarize the entire idea of balanced transfusion. First, and obviously, there's tremendous uncertainty. There's no clear benefit from balanced transfusion as a whole, right? We have a negative trial and a very negative trial, i.e. increased mortality. Those are our two RCTs. There's no clear benefit from whole blood. In fact, maybe also some indications of harm there. And the evidence is very mixed when you look individually at FFP and platelets. It's also negative for prothrombin complex concentrates, which is, on paper at least, a better version of FFP. So with that summary, when you look at it like that, when you think about the fact that there are pretty clear harms from both FFP and platelets, but not proven benefit, I think it's very clear that we've gotten overzealous with this whole concept of balanced transfusion. Now, practically speaking, clinically speaking, I'll say you should just follow whatever your hospital's protocol says. You are not going to run a great resuscitation if you're trying to adjust all of this on the fly. But if you're designing a new protocol, you should definitely be using 1:1:2 over 1:1:1 right now. And my guess is that future research is going to tell us to use even lower ratios of FFP and platelets, not higher. Now, of course, this whole ratio thing only matters if you don't know what's going on with your patient, right? I think one of the best investments that most departments can make is in rapid testing that can spit out a hemoglobin, an INR, a platelet level, calcium, fibrinogen in close to real time, so that we don't have to give these products blindly, empirically. We often forget this part of the discussion, right? Blind ratios are a band-aid solution to the fact that we don't know what's going on with our patient. With appropriate testing, we can just give the patient what they need rather than this blind, empiric, balanced therapy. Or we can talk about the other testing option that's taking the world by storm, viscoelastic testing. And this might be the most interesting aspect of all massive hemorrhage management. As compared to the other topics I've covered so far, the evidence is actually a fair amount better. It's not good enough to be definitively sure about the exact role of TEG and ROTEM. In principle, these tests give us not just faster information about coagulopathy, but more specific information. They should be able to directly tell us more specifically whether we need FFP or platelets or fibrinogen or TXA, rather than just giving everything empirically. When they might be unnecessary, when they might cause harm, we can just give the exact treatment that our patient needs. So on paper, at least, the idea of rapidly treating in response to a known coagulopathy seems to make a lot more sense to me than empirically giving everybody all of the products. And the initial studies were definitely promising. So there's a 2016 Cochrane review, 17 studies, about 1,500 patients, so not huge studies. And they compared and they concluded that as compared to standard care, the use of TEG and ROTEM reduced mortality. That's pretty good, right? That's the best outcome we can look for. Additionally, TEG and ROTEM decreased our total blood product use. In particular, FFP and platelets seem to be used less when TEG or ROTEM is used. Now, overall, this is low quality data. All of these studies are open label, and we're talking about an average of just like 100 patients per study. So don't get too excited, but these results are all pointing in the right direction. But I really want to pause and think about what this means for the entire concept of balanced transfusion. These tests themselves don't magically save people's lives, right? A test can't save your lives. It's only the actions based on that test. And what's the direct impact of these tests? Well, originally when I heard about them, I thought they were going to increase our use of other blood products like FFP. But we're already using so much of these products that in fact, TEG and ROTEM decrease our use of FFP and platelets. And the result? An apparent decrease in mortality. If these results are real, if there is a benefit from these tests, that is a really damning statement about balanced transfusion, because these results say that giving less FFP saves lives. Say that again. Giving less FFP and less platelets saves lives. That really does not sound like a 1:1:1 strategy is a good idea. Now, the other possibility is that these results aren't real. A very common pattern in medical science is that a bunch of small studies, early studies, are reported as positive, and then bigger, higher quality studies come along and they show no benefit. And this is the result of a combination of factors. Publication bias is probably the big one, where positive studies get published and negative studies get buried, but is also a fact that smaller studies tend to be lower quality. And we're still waiting on the biggest studies underway for TEG and ROTEM, but there was one bigger trial published since the Cochrane review that you will probably hear about, which is the ITACTIC trial. This is 396 trauma patients, so the biggest trial by a good margin, and they were randomized to either standard care or viscoelastic testing, and there was no difference at all. So this could be that standard pattern: small trials positive, big trial negative. But I have to say, this trial was not perfect by any means. And I think the biggest problem, the fatal flaw of the itactic trial, is that even though these doctors enrolled patients that they thought needed massive transfusion, only about 30% of these patients actually received a massive hemorrhage protocol. And you gotta say, it's pretty hard to show any benefit from TEG or ROTEM if you're not actually giving any blood products based on the results. So bottom line for viscoelastic testing, there's still a ton of uncertainty out there. The early results are very promising. And so honestly, if your hospital does enough massive hemorrhage management, I think this is a reasonable investment, assuming that you know that there's a good chance that future high quality studies will turn out to be no benefit and you might have wasted some money on this machine. In terms of our overall conclusions, I think it's again important to emphasize that if you believe that TEG ROTEM help, you are essentially saying that you think giving less FFP and less platelets saves lives. Based on the data we have right now, you basically cannot be a supporter of both 1:1:1 and viscoelastic testing at the same time because they are contradictory. All right, you can't give a talk about bleeding without mentioning TXA. And there's so much data here with so many misunderstandings that honestly, you could spend way more than an hour on this topic alone. In fact, I have a podcast, check out the Journal Jam podcast on EM cases, that I think goes more than 2 hours just on TXA. And that was prior to a few of the more recent studies. So if you're hungry, check that one out. You can get even more data. There is surgical data that goes back decades, and there's a suggestion that there's less perioperative blood loss with TXA, but the surgical studies are generally small and low quality. Obviously, TXA came onto the scene with the CRASH 2 trial, 20,000 trauma patients, and there was a 1.5% reduction in all-cause mortality. That's great, but massive trials don't automatically make high-quality studies. I'm not going to do a full CRASH 2 journal club here, but there were a couple reasons to be skeptical of these results. We debated CRASH 2 extensively in journal club when it came out. Now, don't get me wrong. Personally, I use TXA in trauma, but it would not surprise me in the least if we ever get around to replicating this trial if the results were completely negative. What fascinates me about TXA is, despite the fact that its popularity has skyrocketed since CRASH 2, every single high-quality study since CRASH 2 has been negative. Now, a few have been publicized as positive, but they were all negative. We have more data on TXA than we do on everything else that we've talked about today, and it is essentially all negative. In GI bleeds, we have the HALT-IT trial. No benefit, increase in clotting. In uncontrolled epistaxis, we have the NOPAC trial. No benefit. In postpartum hemorrhage, we have the WOMAN trial. And this one will probably be the most controversial because people have been misquoting these trial results extensively, but this was clearly a negative trial. Their primary outcome was negative. There was no difference in hysterectomy, and there was no difference in all-cause mortality. But after the fact, they decided to publicize the outcome of looking at death due to bleeding. But disease-specific mortality, death due to bleeding, is not a real thing. People are either alive or dead. Don't make me get Monty Python on you. There is no such thing as death due to bleeding. And all-cause mortality in the woman trial was exactly identical between the two groups. So if less people died due to bleeding, it just means that they died from other causes. They were still dead. The woman trial was clearly negative. There's another postpartum hemorrhage trial, the TRAP-1 trial, also negative. There are 2 trials for postpartum hemorrhage in the setting of a C-section. The TRAP-2 trial is interesting because it was, again, statistically positive, but if you look at the outcomes, there are just absolutely no differences between the two groups. On average, there was a 30 ml difference in blood loss between the two groups. That's not consistent with TXA decreasing bleeding. Transfusion rates, the amount being transfused, everything was identical between the two groups. TXA had no clinical impact. And then there was another 11,000 person trial published just last year in 2023 that showed clearly no benefit from TXA. In non-traumatic intracranial hemorrhage, we have the TITCH-2 trial, no benefit. In traumatic intracranial hemorrhage, we have the CRASH-3 trial. This is another one where they decided at the time of publication to change their outcomes around, and they changed it to that disease-specific mortality rather than all-cause mortality. But their original primary outcome, there was no benefit. All-cause mortality, no benefit. Neurologic outcomes were identical. There's been a subsequent meta-analysis. There's clearly no benefit. Most recently this summer, we have the PASH trauma trial. This one's interesting. Similar patients to the CRASH-2 trial, but they were given TXA pre-hospital. Again here, no benefit, although there's been some debate around this trial because all-cause mortality actually was improved here, but neurologic outcomes weren't improved. So this might be exactly consistent with CRASH-2, but it's also possible that we're keeping people alive only to put them in nursing homes. Look, the main argument that people give in terms of giving TXA despite negative data is that it's harmless and it's cheap. But listen, anything that fucks with coagulation will have some harm, and we did see clotting doubled in the HALT-IT trial. But I think more concerning to me, look, there's a recent push to give TXA as early as possible. And the reason is, if you give it before 3 hours, it looks really good. But after 3 hours, it looks bad. And by bad, we mean that after 3 hours, if you believe this data, TXA increases mortality. If TXA can increase mortality when given after 3 hours, you cannot claim that it is a safe drug. That doesn't make any sense. So either you have to abandon all of the time-based claims, which is probably the right thing to do, or you have to admit that there is the potential for major harm from TXA if giving TXA late has the potential to increase mortality. Now, once again, TXA overall summary. Look, there is still uncertainty here, but I think there's a lot less uncertainty than there was for everything else we've discussed. Basically, every high-quality trial since CRASH-2 has been negative. And yes, you can always debate trials, but these are big trials, and they have all been negative. Personally, I give TXA in the CRASH-2 setting trauma. I'm not overly convinced that it even works there, but I still do it. But I don't give it in any other clinical scenario because all of the rest of the data is very clearly negative. This might get better in the future. Maybe, look, if we gave TXA only to the subset of patients who needed it, because viscoelastic testing told us they needed it, that might make sense. Theoretically, that's how you would maximize the benefit from TXA, but again, we would want to see some data to actually support that. All right. Fibrinogen is another pretty important topic. It's a really important part of the clotting cascade. In patients who bleed a lot, we know that the levels will consistently fall, partly because you're just using up your stores and partly because we're diluting it down with all the other blood products that we're dumping into our patients. When I originally wrote this section, there wasn't a lot to say about fibrinogen. The observational data says that outcomes are worse when you hit a level below 1 or 1.5 grams per liter, but it's really not reliable observational data. There were a few small RCTs in the past. There's one in postpartum hemorrhage with no benefit. There's some mixed results from coronary bypass and aortic surgery. One stopped early because of harm, but a few others showing decreased blood product use. But just before I got on the plane to give this talk, we got the CRYOSTAT-2 trial, biggest trial by far, 1,600 trauma patients randomized to either get 3 units of cryoprecipitate or nothing in an open label trial. There was absolutely no difference in the primary outcome of mortality and no difference in any of the secondary outcomes. Now, of course, this is not a perfect study by any means. My major concern is that all of these trauma centers were already giving a fair amount of fibrinogen as part of their massive hemorrhage protocols. So we're not cleanly looking at fibrinogen versus no fibrinogen. We're looking at like some fibrinogen versus more fibrinogen. So there's a ton of room for future research, but the biggest trial by far is negative. Bottom line, right now, despite CRYOSTAT-2, there is still a ton of uncertainty. There's a bunch of more big RCTs pending, so expect to see some changes here over the next few years. Clinically, I don't think that you should be giving this automatically, but it makes sense to check levels regularly, and the general advice is to keep the concentration above 1.5 grams per liter. Our last two topics can probably both be summarized on the exact same slide: calcium, temperature management, good physiologic theory for both. Calcium is an integral part of the clotting cascade. The more citrated blood products we give, the lower we know it's going to fall, and our clotting factors do not function properly at hypothermic temperatures. But the data for both is basically the same, basically non-existent. There are associations, but they're based on very low-quality observational data. But not only are the observational trials, very low quality, but the confounding is obvious. We never let our trauma patients get hypothermic on purpose. We'll always put a warming blanket on them if possible. So who becomes hypothermic? Well, it's the patients in the field who become trapped in their cars with long rescue times, or it's the people in the department who are getting multiple procedures. It's really hard to manage hypothermia when you're placing bilateral chest tubes or performing a thoracotomy. But in those cases, it's probably not the temperature that's killing the patient. It's probably just that the sickest patients are the same patients who become hypothermic. Clinically speaking, for calcium, there are very few harms from giving a few grams of calcium. One thing that we almost never talk about is that blood products contain a lot of potassium. Each unit of packed cells has at least 30 milliequivalents of potassium, but maybe as much as 80 milliequivalents, depending on hemolysis. So when we're slamming units in, hyperkalemia is very common. Another reason, just give a little bit of calcium. Despite the lack of evidence, the limited harms from calcium mean that I do give calcium empirically. Ideally, this would be guided by labs, and I'll change the labs as soon as possible, but during that initial chaotic phase of resuscitation, I give a gram of calcium with every round of 1:1:2 balanced transfusion that I give. For temperature, look, we don't want our patients to be cold. Don't do stupid things because there's no evidence. I've seen a number of trauma resuscitations that went incredibly wrong because people were struggling to get in a chest tube or struggling to get vascular access because they left the bear hugger in the way, right? The hypothermia should not become before life-saving interventions, but of course, as long as it's not interfering, there's really no reason not to keep the patient warm. All right, that's a lot, and my voice is about to give out, but that is all of the data that I wanted to go through for this talk. I think there's two different ways we could summarize this data. There's the clinical summary and the evidence-based medicine summary. Let's start with the clinical summary, both because it's relatively simple. There's not that many clinical steps. It's not that different from what we went through at the very beginning of this talk. The best thing we can do for these patients still is to keep their own blood inside them. Step 1 is still stop the bleeding. Step 2, start with that stat pack, 3 or 4 units of red cells as your initial therapy, and then you're going to use that as your decision threshold. If the patient still needs blood after 3 stat units, you activate the massive transfusion protocol. The big difference from our initial summary is that we don't want to use a 1:1:1 ratio. 1:1:2 might be the best evidence so far, although I expect it will go even lower than that. And then we're going to make sure our protocol includes some approach to both fibrinogen and calcium as well, although the evidence doesn't tell us what the ideal approach is. Ideally, we want to move beyond empiric therapy as soon as possible. We want to guide our therapy based on labs, and that could be bedside testing, rapid bedside testing of INR, CBCs, fibrinogen, calcium, or it could be viscoelastic testing. The sooner we move from empiric treatment to a specific treatment, the better, because it will limit how many unnecessary blood products we give to our patients. We want to limit further bleeding if we can, so that's going to be to reverse any coagulopathy, TXA, but that probably only has a role in trauma and in no other bleeding patients. Supportive care still matters, and you still want to have a reminder to let the lab and blood bank stand down when your patient is improving. So that's our somewhat simplified approach to massive hemorrhage. The evidence-based medicine summary is a lot more complex. Look, this talk contained a ton of information, and there is a ton more that I read when I was trying to prepare for this. But I think the evidence-based medicine summary is the more important summary, partly because The clinical summary we just did is bound to change over the next few years. You heard it. There's massive uncertainty in this data. So expect future trials to conflict with current practice. And I know some people find that frustrating, and I understand that. When I have a sick patient in front of me, I just want to know what to do, but I worry we take that too far. We simplify too much, and then we teach the simplified version, and the simplification becomes dogma. And a new generation of doctors is not even aware that the uncertainty exists. There's something that I refer to as evidentiary amnesia, and it refers to exactly this. With time, we seem to forget about the flaws in our data. When CRASH 2 was first published, lots of people talked about the huge limitations in that trial. But over the last decade, TXA has just become standard of care in trauma. A lot of my students aren't the least bit aware that there was any controversy with that trial. For balanced transfusion, it's maybe even worse. The only trial we have, proper, is the only RCT we have, really, and it was a negative trial. There's no good evidence that balanced transfusion is good for patients, but every conference that I go to, 1-to-1-to-1, is talked about as if it's the standard of care. Evidentiary amnesia matters a lot. First of all, it makes us resistant to new science. Therapeutic hypothermia after cardiac arrest, right? There were 2 tiny trials in the 2000s. They were unconvincing, but somehow hypothermia became the quote-unquote standard of care. And so when TTM was published, a lot of people were unconvinced, even though it was a much bigger and much higher quality trial. Then TTM2 was negative as well, and people were still unconvinced. And there are lots of centers out there who are still cooling their patients. So now we have to run TTM3. We get inertia from these early studies because we forget that our quote-unquote standard of care is not based on strong evidence, or even worse, is based on very weak evidence. I think more important, we often feel stuck. When something is talked about as if it's the standard of care, doctors lose their flexibility. One of the first patients I saw in my career was a young woman who had a STEMI. Then she fainted and fell down a flight of stairs as she was going downstairs to make a phone call to 911. She had a subdural. Neurosurgery refused to take her because she, quote, needed to be on heparin, quote, for her STEMI. Cardiology refused to take her because she was going to, quote, die without neurosurgery, quote. But did this patient actually need heparin? Turns out, no. The benefit from heparin is not 100%. In fact, the benefit from heparin is completely unknown. We let a woman in her 50s die because everybody, including me, was so stuck on guidelines that we forgot about or just never knew the nuance and uncertainty in our evidence. So when you're resuscitating a hemorrhagic patient, it makes sense to start with some agreed upon protocol. You don't want to make up every resuscitation on the fly. You want blood bank and everybody else to be on the same page, but you need to feel free to deviate from that protocol. If the surgeon's having a hard time stopping the bleeding, it might make sense to give Fibrinogen or TXA no matter what the protocol says. If the patient has a history of severe allergic reactions, look, limiting the number of blood products, and specifically FFP, starting with just packed red cells, might make sense over a balanced transfusion, at least to start. Embracing the uncertainty, the massive uncertainty in this data, allows you to stay flexible. It allows you to apply your clinical judgment. And it allows you to change more easily, at least, when new data becomes available, which for this topic is a near certainty. So I hope there were some tidbits of value in there. Obviously, it's hard to make a practice-changing talk when faced with incredibly uncertain evidence. But to me, just knowing how uncertain this all is very valuable because it means that I won't be stuck in my ways. I can anticipate the results of future trials that are going to conflict with our current practice patterns, and I can still allow my clinical judgment to be applied to the patient in front of me.